hi everyone, this is Shine Connect's menopause question and answer session. So if that's what you came for, you are in the right place, and we have just the right guest for you. We have Dr. Mourad Seif. Have I said that correctly?
Yeah, almost Mourad.
Almost. Please say it for me.
It's Mourad Seif, yes.
Thank you so much. And you are the lead consultant at the Manchester Complex Menopause Clinic.
Correct. Yes,
Yeah,
yes.
And have decades of experience in this area.
Well, it makes me feel old, decades.
Oh. Well, it is so nice to have someone with us that, you know, really knows about this and can answer. So many of you sent in questions already, and that's what we're going to work through today. There's going to be a little bit of, even with some of the questions that we got, very similar, just coming from slightly different angles. So we will be going through that today. And just to let you know about me, I had breast cancer at 35. I had my ovaries removed without HRT. And I personally found that to be not just debilitating for a short period of time, but really for, you know, for 10 years. And I didn't really get any help with it. And then I finally did, and it changed things amazingly for me. So I'm really passionate about getting information out there. And so this is what we're going to do today. And, you know, knowing that there are things. And so even knowing that things are possible or what to ask for is, I think, you know, the first step. So, Dr. I'm going to say your name again, Mourad Seif. Did I say it correctly this time?
For simplicity, we'll make it Mourad.
Mourad.
Yeah, we are. Yes, indeed. Thank you very much. First of all, I really like to thank Tatoon and Shine for giving me this opportunity, because I really feel since I started this service decades ago, it was essentially a service to provide support and management for complex menopause. So I'm the lead consultant there at St. Mary's, Manchester. I have clinics full of not only cancer, but patient after cancer, patient after renal failure, patient after clots in the lungs, and so on and so on. So it is not a straightforward bread and butter menopause clinic. It is complex one. So my experience, actually, I'm very grateful to my patient who gave me this chance to support them, because I gained a lot from listening to them and trying to support. So please feel free. It's this session is not a consultant and a patient sort of formal session. This is to try to fill some gaps which you may feel needed to link between you and your caring clinician. I fully appreciate that many of you have or concerned regarding breast cancer, but cancer is not just breast. Cancer in women, there is endometrium, that is lining of the womb, and there is also childhood cancers, and there is cervical cancer, that's the neck of the womb. And please, I don't want this group to be missed out from our discussion today, being dominated mainly by breast. So if any of you have other than breast cancer, please feel free to jump in.
Lovely. And can I ask, for those of you that you see, for the people that you see coming into your clinic, what are some of the symptoms that are like most common, and what are the kind of psychological effects that you see most commonly?
Well, most commonly, obviously, the symptoms are essentially originated or caused by the lack of estrogen once you have the ovaries removed or treated by chemotherapy or radiotherapy. So in this case, menopausal symptoms, it's amazing how we as clinicians learning more about menopausal symptoms. In the old days, and I mean in the old days, it was only hot flushes and night sweats.
Right.
But these days, we're talking about brain fog, lack of concentration, and a lot of cognitive symptoms that all together are bundled into, at the end of the day, is a quality of life. And so we try to fill this sort of cover these symptoms, but I will not be surprised if there is more and more symptoms coming up. As we raise awareness of women of menopause and the effect of lack of estrogen, as I say, the more dominant symptoms these days are brain fog, lack of concentration, loss of libido, dryness, and so many sort of this line of symptoms. I particularly fortunate to deal with highly professional people as well. And if you, I'm sure many of you will be in the same boat when you find it very difficult to deliver your job, whether you're a judge or a barrister or a doctor or a nurse or so on. So that is really the issue. This is the challenging issue. And you cannot put your finger on one or two symptoms that's causing this obstacle for you to have a quality of life.
Yeah. And what do you wish that people or doctors, other doctors knew more about? Like if you could share a piece of information about the menopause, what do you wish that was more understood, either by other doctors or by women experiencing it?
There's two different issues here. Women experiencing, they need to be aware that there are services to support them. That they need to come forward, and there is a lot of sort of resources. Probably it's limited in some areas more than the others, but they need to be conscious that this is not something to live with. That's the important thing. There is solutions, and there is support people here, expert to help them to cope with what they have. From a doctor point of view or clinician point of view, I must admit, regrettably, we need to raise awareness of primary care, particularly of the need to support women in menopause, or sort of not necessarily by just promoting hormone replacement therapy, but by good understanding of what's the implication of menopause on quality of life, on the daily, whether professional or domestic life in a way. So we really need to make or to raise awareness of the clinician to need to support these women. We of course we hear about overstretched NHS and the workload of primary care, but at least raising their awareness is important, to at least to, if they cannot provide the management, at least to advise them to go into the normal the channels to have support and help.
Yeah, and I think, you know, there's really no way to kind of underestimate, like if your sleep is incredibly disturbed, that's going to affect every other part of your life. Like there's every other system of your body is affected by that one. And I think in a way, that's one of the things that's so tough about menopause, is that it's so systemic. It can be so that, you know, especially when you're going through cancer as well, it can be hard to be like, is this the treatment? Is this Oh, I can hear oh, thanks for muting whoever did that. Appreciate that. It can be really overwhelming, and something that, if that goes on for a really long period of time without help, can exacerbate other issues as well. So I'm really glad that you've said that, you know, there is help. There are things that can be done.
Taton, you really raised a very important, simple point. If you don't sleep at night and expected to go to your job the following day, this is something so simple that you can imagine the impact of that on your performance and or your daily activities in a way. Just something simple as lack of sleep. So
Yes.
I'm glad you raised this point, because this is a very common symptoms that people come with.
Yeah. And, you know, because from what I understand, there's 4 different types of insomnia. And, you know, there's falling asleep, there's staying asleep, and then there's another type where you don't get deep enough into your sleep to actually get that rejuvenation. So you know, almost like when you're drinking, when you don't get into like that really deep rejuvenative sleep, you think you've slept, but you haven't. And I think hot flushes throughout the night really mess up that sleep. And I know for myself, it felt like one long day that went on for 10 years. Like I wake up in the morning just as exhausted as the night before, and that just went on for day after day. Because there was never really that like good sleep. And I think that can't be underestimated. So I'm going to start with some of your questions now. So the first question I have from our lovely Shinies is, my cancer is triple positive, so I won't be able to have HRT. Are there any recommended alternatives to help with hot flushes, low mood, protecting our bones, and all the other weird and wonderful symptoms? And that's obviously a really big question. So let's start with the hot flushes. Since we were talking about that, and the hot flushes, night sweats, they're really linked with that disruption of sleep, and also getting really, really cold in the middle of the night as well can be just as disruptive. So anything that can be done for those hot flushes if you can't have HRT?
I'm glad you managed to answer half the questions on my behalf, because this bundle of symptoms that you mentioned, or bundle of concern, from hot flushes and night sweats, that's a vasomotor issue. Then you mentioned bone, and you mentioned other things. So the fact of the matter is that once we avoid estrogen, which will target all these sort of fronts, we have to take each one separately. So for hot flushes, yes, there are a number of medical and non-medical sort of solutions. I have to say that the non-medical one, or the alternative therapy, or the like hypnosis and acupuncture, etc., we can put this in one group, because the evidence sometimes is not as strong as you get from medical treatments. Medical treatment, we have a standard called randomized control trial, which provide good, strong evidence. So based on the randomized control trial, I start by the medical alternative, i.e. the non-hormonal medical alternative. And yes, for example, we had venlafaxine, which is considered as an antidepressant drug, but we are not giving it to you because you're depressed. We're just giving it because it works on hot flushes. Dominated the field for a long time as being a good, effective anti-hot flush treatment. Having said that, 2 or 3 years ago, we came across, there was a paper published in the biggest breast cancer conference and showed that one of the drugs we used for overactive bladder is called oxybutynin, proved to be very good in treating hot flushes in breast cancer women. So that's a non-hormonal one. And this
Can you
is
say the name of that again for me? It's oxybutynin.
oxybutynin.
Because I've been around a lot of menopause doctors, and I was so excited when I heard of this, because this is something that I hadn't come across before, and I imagine other people haven't heard about either. So
it is not widely used.
Okay.
I came across this paper, as I said, when it's presented in this big conference, and I had a good feedback from my own patients that it works. It's a drug used for overactive bladder, and we use a small dose of that. The side effect to be aware of is dry mouth. So be careful with that. And it's just taking 2 tablets a day should help. And I had a very good feedback from my patients on that. Interestingly, just 2 days ago, on the 12th of November, there is another paper published in Lancet, that's the most prestigious medical journal, showed that there is a trial that on a treatment called Q122 that's not available yet, but the trial showed a very, very good response to treat hot flushes in women after breast cancer. So that is very encouraging results. But what does this indicate? It indicates that we're working on it. There is more and more information coming, and this paper is published in the Lancet, this prestigious medical journal, on the 12th of November, only 2 days ago.
Oh, brilliant. Well, it was really good to know that there's something on the horizon. And I think when you were talking about venlafaxine, like, a lot of people feel that the doctors are kind of fobbing them off with an antidepressant. But what you're saying is that the antidepressant is really being used for its hot flushes.
Yes, but I don't want to lump them into one category, antidepressant, as a group. No, the data we have is on venlafaxine, right? Because
so it's a specific type.
Yeah, I see a trend in GPs giving women antidepressant, even not with breast cancer, just treating their symptom with regular antidepressant, which is not the case. The data we have on venlafaxine, and we have some data on gabapentin and other group of non-medical, but the one that's been sort of popular is venlafaxine, and more recently the oxybutynin, and we hope this new treatment will come. The trial is done in Australia and United States, so we've not had any data from UK yet, but at least it's giving us some hopes that there are more medication coming up.
Great. And if someone can't take HRT, is there anything that you would suggest for protecting bones?
Definitely. Again, after breast cancer, those who are on tamoxifen can be reassured that they have, tamoxifen is good for bone.
Okay.
Because tamoxifen it's like estrogen, it does support bone. Similar to raloxifene and this group it's like we call them estrogen receptor modulator. So tamoxifen is good for both. Having said that, if you are not on that, we do advise dietary and exercises. Dietary, particularly with vitamin D. There is some interesting information that I think people need to know about vitamin D. Apparently, 8 out of 10 in the UK are vitamin D deficient.
Yeah, so high, isn't it?
It's very high. It's very high because we tend to work indoors. There is no much exposure to sun. Let alone Manchester is not the most sunny place. Then COVID came and we worked from home and we stopped traveling abroad. So while the recommendation for vitamin D is to have 400 international units per day, the advice currently is to have 800 international units per day, particularly in the months of October till March, where there is really deficiency in that. Then we talk about calcium, another important ingredient for bone protection. And there are so many sources of calcium, whether dairy products. You need 1 gram per day. If your diet is not contain this source of calcium, you may consider having calcium tablets 1 gram per day. Then we talk about exercises, and the exercise is considered, or the beneficial exercise is weight-bearing exercise. I couldn't stop smiling when my patient understanding of weight-bearing is to carry weight, lifting weight. No, weight-bearing exercise is the exercise that hit your bone and lower spines, like walking, jogging, aerobic, this sort of thing.
So I was so glad that walking was in there, because I personally was not designed for running. I'm sticking by that.
Very good.
People laugh if they see me run for a bus. I just flail. So, so I'm glad that we don't have to run if it's not in our natural thing. But walking is still considered weight bearing. Now,
it's your weight bearing. It's your weight that's bearing on the hips and the lower spine, not that you carrying weight.
Okay.
So swimming, for example, swimming is not.
Swimming wouldn't do it. Yeah. And going back to the vitamin D thing, we had a comment that came up. Is there other times, or if you're kind of in treatment, that maybe you should have like a higher dose of vitamin D, or is that something that you check in with your doctors about? Because I know some people absorb it better than others. Is that something that you just monitor on your bloods?
They are exceptionals. Having said that, as I said, the recommendations is meant to, as 400, but we advise 800 international units.
Okay.
So you're reasonably safe by going for the 800 per day. If you take it regularly, and there is some also an added value. Vitamin D is also it's suggested that it supports your immune response, etc., which is again another added benefit to that. And vitamin D is very cheap.
Yeah. And I also discovered that you can get them in gummies, and so I never forget anymore, because it's like my candy. I have it like with my cup of tea in the morning, and it feels like such a treat. I've never forget my vitamin D now. I've treated myself with
very good. And regarding calcium also, we of course we understand that calcium there is a lot of products that have added calcium to it. And for those who are vegetarian, for example, there is soya soya milk with added calcium, orange juice with added calcium. Nuts are very good for calcium. Green leaves, vegetables like spinach is good source of calcium. So there is a lot of that suits everyone, whether you are vegan or vegetarian or otherwise.
Brilliant. Thank you so much for that. So going on to the next one, and this comes up a lot. This person wrote, I have secondary breast cancer and can't take HRT. My symptoms have been quite severe, but one of the worst is the vaginal changes, which has made it difficult, impossible to have penetrative sex. The only medical advice I can get is to use moisturizer, which doesn't make much difference. Surely there must be something else. So
yes,
so
that's another important point, because the standard practice is to avoid every form of estrogen, right? And we learned over the years that vaginal estrogen is not really absorbed by the body, and it only acts locally. To understand that, the lining of the vagina, the epithelium or the skin lining the vagina, is nourished in estrogen and estrogen alone. Lubricant is just to facilitate, but they are not nourishing the skin of the vagina as such. So more recently, and the data are supporting that local estrogen, vaginal tablets or vaginal creams, are not really absorbed by the body and can be used to improve the vaginal condition and to moisturize more effectively the vagina. But obviously, after years of no sex and no estrogen, if you're going to start from or using vaginal estrogen after all these years, there will be a need also for supportive other measures. While we're nourishing the skin of the vagina, there may be a need for some dilators as well to overcome the narrowing of the vagina that took place over the years.
Yeah. So, you know, just because you've gotten the cream that's going inside, you still need to take it step by step, nice and slowly, and to get there.
Yes, because again, I'm learning from my patient, many of them don't like the cream. They consider it as very messy.
Yeah.
So there is a little vaginal tablets of estrogen, very small tablets that can be put in the vagina once daily to start with, and then twice weekly, maintained as very low dose as twice weekly. But the idea, step by step, if you're starting the estrogen vaginal tablets soon, obviously you will not have this narrowing of the vagina. But if you're starting late after narrowing did occur, so you will nourish the vagina first, and then you go to the next step of dilating the vagina.
So one of the things that I've also seen and heard about and experienced myself is that from taking the cream is that it also stopped the need to get up and go to the loo in the middle of the night as well. And for a lot of people that kind of have that feeling of a low grade UTI infection, they often feel that like the kind of the plumping up of the tissue has some effects with that as well. And they seem to have less of that feeling of a UTI coming. So that whole region around there kind of likes the estrogen. Is that correct?
Katon, I'm really impressed. I think I need to have you in my clinics.
Well, I'd love to come to your clinic.
So, because it's true, when we talk about the vagina or the symptom of atrophy here, atrophy means sort of shrinkage. We're talking about urogenital. not just genital, we're talking about urogenital. Because without making it too complex, the back of the bladder, the base of the bladder, is affected by estrogen as well. So in a way, when with the lack of estrogen, is not only affecting the lining of the vagina, it's also affecting the bladder as well. So here, when the problem occurs, you find urgency, you find frequency, you find pain with micturition. And once you nourish this area with estrogen, as you said, you will feel the frequency is less, the urgency is less, and even the control is better to some extent. And in fact, it is a standard now before you go to the doctor, the specialist, for having complaining of stress incontinence or urgent incontinence and this sort of thing. They make sure that if you're menopausal or lack of estrogen, that this area is well prepared with estrogen first before any intervention is needed.
So, I mean, you know, it really is such a great option that is now available, even, you know, for people that have cancers. You know, I mean, obviously, if any, you know, you can always check, obviously, with your individual doctors, but now they are being given more and more because they stay in that area. And then get to kind of positively affect your sex life, you know, going to the bathroom, like that makes such a big difference.
Yeah. In this respect, I'd like to mention something. I'm not defending my other colleagues, etc., but there is no doubt the textbook on managing the menopause, particularly after cancer, etc., has not changed for decades, right? So the textbook and the drug information say it's contraindicated. So in defense for the primary care or the GP who say no, we cannot prescribe it, they are following the textbook and they following the drug. When you read, many times I prescribed something and then the patient come back to me and they said, look, I read the information here and it's saying it's not suitable for me. So it's only by specialist clinic where we rewrite or we have some flexibility. And in this extent, I want also to take this opportunity talking about vaginal estrogen. Is anybody of the attendee had endometrial cancer? That's the lining of the womb cancer? No, because another example of the extended use of estrogen, in the past, the lining of the womb or endometrial cancer is a contraindication for using estrogen whatsoever.
Okay. So
now we do give it to early cancer of the endometrium because it's totally excised. It has a good prognosis and we don't see any recurrence. So you can see that we extended a little bit the indications and we suppress some of the contraindication, but that's at the discretion of the consultant that you are seeing.
Yeah, I mean, it's you know, kind of a, not that any of us want to be in menopause before our time, but it is quite, you know, compared to even 5 years ago, the thinking around so much of this and the conversations have really increased, and you know, there are more options, which is quite encouraging. Can I ask you, so we've got a question here for someone that can take HRT, will it help with mood changes? They said they're struggling with severe mood swings and rage. I'm not a good person to be around right now. I feel like I'm losing my mind. Is that you're smiling? And I imagine that's because you hear that a lot.
I do. You said somebody's taking HRT.
They can take HRT, so they're not yet, but they're not prohibited from it.
Right. There
So
are two
they,
issues here. They can take HRT. Yes, it does help mood swing to some extent, but those who are taking HRT and having more or mood swing and some adverse effect, many clinicians will think this is because the dose is not appropriate or this or that or the other. Another piece of important information, if you are taking HRT as a sort of combined HRT, that is estrogen and progesterone, right? The progesterone is the one that we can blame for causing this mood swing, aggression, sort of very bad side effect. And these days, most of the HRT's preparation are having these synthetic progesterones, which are the one that cause all this bad side effects. So if you're taking HRT already and you're having mood swing, think, or your doctor need to think of what type of progesterone supplement in this HRT. It can move you to a different one, or can move you to a more natural one, or can give you a different type altogether of progesterone supplement. But for those who are not having HRT and having these symptoms, yes, it does help with the mood swing and this cognitive type of symptoms.
So yes, if someone's just put in the chat, yes. So if you go on HRT, the chances are that it might help with the mood swings, but if it doesn't, and I think this points to a bigger thing about HRT, is that it might just need to be tweaked a little bit. You might need to make sure you're on the right progesterone. You might, so if you go on HRT, it's not necessarily going to be perfect first time round. It might need a few months to see how it is and then potentially tweak it.
No, it will help. It will help to start with, right? Mm-hmm. But if you continue or develop new symptoms of mood swings, etc., you will find that this is coming from the progesterone side of it rather than the estrogen side of it, or it's coming as a side effect, whether newly developed or exaggerated by the progesterone component. And although you're still having the benefit of the estrogen part, but the progesterone component is not suitable for you. And in fact, I tell you, for example, that's very clear. I have a special interest in this particular one. You see the intelligent patient, if you go, you know, the HRT can be cyclic or can be continuous as no bleed. And the clever woman will tell me, I have this mood swing when I take these different color tablets. And this different color tablets is the one that has progesterone in it.
Interesting. Yeah. Yeah. So if you can't have HRT and you're having mood swings and experiencing that rage, what would you recommend to someone who can't have the HRT?
Venlafaxine may be helpful.
Okay.
All right, because it has other beneficial psychological effects, right? So it is. I mean, we have to accept the fact that once we are not eligible for HRT or estrogen replacement, right? I like to call it hormonal therapy rather than replacement therapy, and once we are not eligible for that, we have to work within limitations, right? in a way that we try to reduce the symptom rather, probably in some cases, rather than cure them altogether. And you can see we talked about the vasomotor or the hot flushes in one side by one medication, then the bone protection by another medication. So we try to put a portfolio to help you with different symptoms rather than giving you estrogen, which can target all these symptoms altogether.
Yeah, and it's a tough time because I think, you know, after a diagnosis, there's also a lot of reason to be angry as well, and to feel emotional, and to feel, that your bandwidth is just very, very different, and there can be a lot of grief wrapped up in that, and, how things, so it's kind of like that, you'd have all your natural rage and grief, and then you have your hormonal rage on top. So it's really important to kind of honor and address that and be able to get some help with it.
That's true. You're absolutely right, because the trauma of having cancer itself, it's a very strong background to present with these symptoms. So it's not all estrogen deficiency here. And that is why to have support, to have an opportunity to discuss, to have the opportunity to get support from your nurse or your doctor, that's quite important to go through the whole process. Estrogen is only to help addressing some of these areas that we discussed before. But at the end of the day, I fully appreciate, although I'm seeing patients, because I get a lot of referral from our local cancer hospital, which is a very famous European, is one of the biggest center in Europe, the Christie Hospital in Manchester. So I see these cases all the time, and the need for support, and the need at least to allow them, or to tell them there is access to services for support. That's quite important.
Yeah, it really is. And I think along with that, goes the brain fog. And for me, it was finding my words. And that was the thing that kind of made me feel like I couldn't work at the same level. Like someone would ask me a question, especially names. So I get like, even people I've known for 10 years, I could look at and be like, yeah, not a clue. And so I've become very kind of, I move through life without saying too many names. I've actually forgotten my own name before. I have told that on a Shine thing before.
I hope you don't forget me after this session.
I'm not going to forget you, of course not. But I mean, I think, another name came out of my mouth when I was trying to say my own name, and really feeling like my brain was broken, and I think a lot of people feel, again, that kind of taps into like everything else that feels a bit out of control. And some people actually feel it's early dementia. Have you heard people coming to you kind of saying that about their brains? And
that's true. That's true. And that is why I admire the work you're doing and Shine is doing, because talking about it, at least you at least you feel you're not on your own. That is another important thing, that you're not alien, you are not on your own, and there are other people like you. And so for that reason, I really admire the work you are doing, you guys, in having sessions like that for people to talk and discuss and express and share their experience together. It's a very important element of managing menopausal health, particularly after cancer. So thank you very much for giving this opportunity.
Oh, yeah, that's coming in the chat. there's other people saying, noticing that I'm struggling with my words and my cognitive capacity. Having this, someone else saying, having exactly the same issues with finding words. I thought I was going mad when it was happening. Yeah, when it started for me, I developed almost a stutter, and I had been, you know, kind of, I did a lot of work where I was on stage, and suddenly just, you know, talking to my neighbor, I would be stuttering and stumbling over words. And I think, yeah, someone else is saying, yeah, people's names, nightmare. It really is. It's like, it becomes so, but I think that's the thing, is like you said about talking about this, is that as we become a bit more comfortable with it, that you know, and having a way of explaining it, I think having a shorthand for it, you know, that's suitable in certain spaces can actually at least take a little bit of the pressure off and go, okay, I'm not going crazy. It's just my hormones.
That's another very important point you're relating to, because you have to adapt. I mean, after the initial sort of an anxiety of how come I used to on the spot, but I think when you talk about it and when you share this experience with others, you will realize that there is an opportunity, or there is a chance to cope with that by adapting to some extent, rather than rushing in words like you used to do and this sort of thing, and you find your way. I'm not going to tell you my trick when I see a patient in shopping, and I obviously I can't remember her name, and how are you, and he's and this and that and the other, and you find a way, oh, nice to see you after those years, and this sort of thing. You find a way to just to start the conversation, make her welcome, but forgetting the name until she say, oh, I saw you in the clinic on such and such a day.
Yeah. Oh, I imagine that it's really tricky when you're seeing a lot of people like that. So someone has put in here the GP suggested clonidine for hot flushes.
Clonidine.
Yeah.
Yes, it's in the long chain. It's popular by GPs. It's a drug that was used for blood pressure, right? And in the chain of venlafaxine became more superior than clonidine. Clonidine is very popular for GPs.
Okay.
I personally not a big fan of it, but this doesn't mean that it's the wrong drug. I am just having my own sort of views based on what my patients say. So clonidine is an approved drug and very popular by primary care to prescribe it for hot flushes. I personally, my practice particularly, I'm not trying to, I don't have shares in the company for oxybutynin. I have to reassure you that. But having moved from clonidine to venlafaxine and now to oxybutynin, I feel it's becoming my first choice from what I heard from my patients.
Do you find that when one area of the menopause is being addressed, or someone's being supported in one area, that it sometimes falls into other things start to fall into place? So like if the hot flushes are being addressed, even though that's only one small part, then people are getting more sleep. And if they're getting more sleep, then perhaps their mood is a little bit better. If their mood is a little bit better, then they're, you know, do you ever find that then the brain fog is a little bit less?
Of course, because we talked about it the other way around, right? When we said it's like a domino effect. So you get low sleep, you get into tired all the day, you get into brain fog, you get into this and that and the other. So you're reversing the domino effect in a different in that way. So of course to try to or one area will improve the other, because it is not so segmented, if you know what I mean.
Yeah.
It's no fractionated. And what we're talking about is not really menopause as HRT full stop, or hot flushes full stop. No, we're talking about the health issue. It's a big container of health and quality of life. I keep lecturing on that. We look at data in medical journals talking about bad effects more than good effects, right? And none of these big, huge mega trials talked about quality of life. And that's very important, very important. I have patients, young patients, who went on HRT despite being contraindicated, because they felt that they cannot cope with any other medication or any other methods. I'm not encouraging you to do that, but I'm saying that this is the value, that each individual has their own values and in their own needs. So you are right. One area, if we start from the sound line, it's like an escalator, we will feedback or we will improve in other areas.
Yeah, I think that's, I know for me, like getting the topical estrogen and being allowed that for the first time. And I went for dilator therapy with a nurse, and then I dated, and then like I had sex for the first time in 10 years, but like penetrative sex, and like my confidence went up. And then when my confidence went up, then when I forgot my words in public, I didn't feel as embarrassed, because it's like one of those things. I think with all of this, it's so interconnected. And what I would feel is, even if you go to a doctor and they're not necessarily know about all the different things, even if you get help in one area, sometimes that can be enough to take the edge off and then kind of work on the other things. But sometimes it can feel so overwhelming. And I saw in the chat a little bit earlier, someone had their ovaries removed 7 weeks ago and has been given zero help, or information. And that it is so important. Like, I think a lot of us feel, that doctors, like oncologists, are kind of like, oh, that's the least of your worries. Do you know what I mean? We're dealing with, but actually, like you just said, quality of life is a huge thing. And that getting help in one area of it, at least, can start to roll things to make things feel less overwhelming.
You mentioned two important points here. I need to emphasize on that. One is the lady who had her ovaries removed. This is another subject probably I'm glad you give me a hint on that. People who will have their ovaries removed to reduce the risk of breast cancer, BRCA patients, they obviously, they're told that taking the ovaries out will improve or reduce the risk of breast cancer. And so they left menopause prematurely without any help. We, as specialists, and I'm a big fan of that, is I do prescribe them HRT. The challenge for the woman is, how come you're taking your ovaries out to reduce my risk of breast cancer, and now you're giving me HRT that's known to have a bit of increase in risk of breast cancer? How come? The data is very clear. You're having the benefit of having your ovaries removed is far more exceeding of any added risk by using HRT, i.e., you gain that amount of benefit from having your ovaries removed prophylactically to reduce your risk of breast cancer, and HRT will add very little risk after 5 years of use. So you shouldn't be concerned to have or to consider having HRT after your ovaries removed to reduce your risk of breast cancer. And that's very important message for those who are having their ovaries removed to reduce the risk of breast cancer, i.e., they've not had breast cancer yet.
Right. Yeah, so that is, yeah, a really big change. And I think that's the thing with, you know, it's hard to sort of, you know, someone wrote a question, they're deciding between tamoxifen, an aromatase inhibitor, ovarian suppression. You know, there's so many different things that are being done in this area and actually have slightly different risks, and I feel like I can see the time we could be talking about this for like a week, but what I imagine is that with any of those, it's really finding out what can be done for the menopausal effects that you will have. So
before we leave, I just want also one of the very subject very close to my heart is if we have any teenagers or very young premature menopause in the group.
I know I saw someone that was 25, but generally in Shine, people are in their 20s, but some have had cancer in their teens.
Yes, because I just
20s, 30s and 40s, but yeah.
I don't want them to be missed out if we had or in this discussion. Fantastic.
Oh, lovely. Thank you so much. Is there anything else that any resources that you would recommend us look at, or places that you think is good to get information?
Yes. I mean, I'm sorry to repeat that what you're doing, the work you are doing is so useful. It's so helpful to support. And these sessions are very, I mean, admittedly, yes, it was very short notice, but I felt that there is a big value, and thank you for giving the opportunity. So a forum like that is very important. I can refer you to one of the interesting publication which was published a few years ago from a colleague of mine in Australia, Martha Hackey. Can I show just a second? I think,
yeah.
It's very interesting reading, because although things are changed since, but at least to give you a bit of a classic framework of managing menopause without HRT. Just let me see if I can find it for you. I will show it in the screen, and I can text you with the full reference later on, so people can read it in their bedtime.
Yeah, we can send that out.
It's very nice flow chart.
Oh, cool.
Yeah,
that looks really clear.
so it is clear, although you will find it's a little bit of oldish fashion, but at least is showing what non-medical and non-medical hypnosis, acupuncture, etc. So it is a very good attempt, and I will text you with the full reference. Right?
Amazing. Yeah, that would be really, really lovely.
And one of these classic papers that comes every now and then, and this lady is very good because she was the the Cochrane Library, which is sort of a very big institute of appraising publications and the evidence, etc. She was my colleague there because I was one of the editors there. And she published this paper a while ago. So with a bit of tweaking of what we discussed, I will send you the reference to circulate it with no problem at all.
Oh, that's wonderful. Thank you so much. And thank you to everyone that's here and that's put information in the chat. I know that it's been useful, just even watching the chat, sort of seeing that some people having kind of similar things going on and knowing it's not just you. And I've seen lots of comments, Mourad saying, see, you know what, it's the name thing. I'm just going to blame my hormones.
All right, yes. Yeah, I will accept that.
Saying thank you so much.
No,
This has been
it's been
such,
a pleasure.
you know, people are saying how incredibly informative this has been. So thank you so much. And if you're looking for more information, definitely we'll send out those resources. There's also a 3-part series in Not Your Grandma's Cancer Show, dedicated to menopause, with an episode on non-HRT and HRT options. So yeah, so if you want to do more of a deep dive, thank you again. Have a lovely rest of your Monday evening.
Thank you very much. Look forward to another session in the future. Please.
Oh, that would be amazing.
No
We'd love to have you back. Thank you. Bye.
Bye, everyone.
Bye, everyone.